be effective and that we'll be able to post the presentation to the web page, which would serve as a resource on an ongoing basis for people. During the presentation today, we will have some opportunities for interaction, and hopefully everyone can participate in those web polls that pop up throughout the presentation to participate in. Otherwise, if you have questions, we have the chat box. We have someone monitoring that, putting your questions into there. If you want to unmute your line and ask a question, that would work as well. And again, if we do have a lot of feedback, a lot of background noises, we will mute all lines. So if you're finding that you're trying to unmute yourself and ask a question or bring something up and you're not able to, that's likely why. So then just chat, type into the chat box the type of conversation that you're wanting to bring up. Okay, we'll go ahead and get started here.
Now we join by computer.
Make sure our lines are muted again here, please. Okay. I think that, just give me a couple moments here. I'm going to mute all lines so that we can have some quality presentation time and really learn the information that we need to glean today.
I have that marketing meeting January 9th.
Yes. Yes.
My computer is being stupid.
Well, they're on.
What's that? Okay, it must just be Flutter on the 13th. You're January 19th. Are they logged here?
Yeah, they're logged in here.
There's nothing there.
Did we lose them?
Right now, I'm just taking a couple moments and I'm muting all lines because we're experiencing several lines that are not muted, and that's proving a little bit difficult for the presentation. So just give me a couple minutes here and I'll mute all lines.
Hey, Ashley.
Yeah.
This is Laura from Benchmark. I just want to remind Benchmark computer users, if your mic on your computer is on, we can hear your conversations.
Thank you. That's very valuable information. Thank you.
Ashley, this is Leah from CIR.
Okay, here we go. I think we've successfully muted all lines. No, we have not. What the hell is happening right now? Okay, I believe that now we are ready to go. All right, so what we have here is a slide introducing the guidelines. At the bottom of the screen, you can find attachments to the presentation, and that does include the most updated guidelines. The last round of revisions occurred in November of this year. They are also located on the CIR website that we can chat about shortly, and they will be located on the DHS website with the website changes that have occurred. We know that there's a bit of difficulty accessing forms and getting online to look at the information right now on the DHS page, but there will be updated guidelines appearing there shortly. Again, these guidelines outline the 12 different types of reportable CIRs, reporting requirements, the authority, and then content requirements. It should only, the presentation is only to be used as a supplement to the guidelines. The contact information for myself appears at the conclusion of the presentation, or you can always contact your assigned program specialist if you have questions. Move to the next slide here. And then if people just joining the call could also make sure that your line is muted. Here are the 12 different guidelines, or the 12 different required areas as identified in the guidelines. As we walk through each of these different types, we will find some information from the 2015 CIR annual report weaved throughout, and we'll discuss that report in a little bit further detail as well. The first type of reportable CIR is the death or mortality CIR. Providers need to report each death as a separate CIR, even if the circumstances leading up to the death were previously reported. And CIR annual report data appears below from the 2015 report, and then also some past trending. So in the table to the left, we have over time the volume of mortalities that have occurred each year, and then towards the right, the leading causes of death. The inside circle reflects the community support provider population from 2015, and the outside circle is the overall statewide data for that same time frame. And this element was a new introduction to the 2015 CIR annual report, and so we will have more information on that in the next report into the future as well, or the 2014 report. Okay, we're going to, we have polls, like I mentioned, throughout, so I'll pull that up here shortly. But first, Cassie is one of the nurses in our division, and I just thought I would ask if you had any questions. Emily said that maybe you all would discuss what you're looking for in mortality CIRs and with follow-up expectations.
We just wanted to reiterate to make sure that there were the two separate CIRs, one for specifically the death and one for what led up to. And really the only follow-up would be whatever's requested from your program specialist or the nurse. Nothing specific right off the bat, I suppose.
Okay, no, that's perfect. Thank you. I think initially Emily was planning to be here, so I think probably throwing poor Cassie under the bus a little bit, so I'm sorry. So I have a poll up here, so if everyone wants to take some time and respond to that poll, I'll move this here. For those on the phone lines only, I'll just read the question here. It's a scenario, and we want you, for those online, to respond with the responses. Samuel is in a car accident and is hospitalized for 15 hours before he passes away that same day from his injuries. How would the CIR be recorded? And it would be to enter, there's some options, enter one CIR, or to enter a CIR for the accident, and then another one for the mortality, or a box for unsure. We have a few 39 responses so far, so we'll give a little bit of time for everyone to work through this first poll question. We won't take as much time in the future poll questions, though, but we'll give you all a little bit here to respond. Okay, so thank you all for responding. The general consensus is that folks should enter a CIR for the accident and another for the mortality. There are 6 responses for entering one CIR, and I think that the conversation we've had here around the table too could attribute to why explain why we've had that those responses, because I think in the past that we had, if there was a cardiac arrest and then a mortality resulting from that right away, it would be all under one, whereas now the expectation would be that there are, I think, CIRs for a car accident, for example, and then another for the mortality. I'm going to get another poll pulled up here. Poll function is brand new to me, so I am trying to make it as seamless as possible. Not on a very quick track with that right now. There we go. Okay, the next poll option is that Lisa is diagnosed with sepsis and receives medical treatment. 2 weeks later, she enters the ER with pronounced symptoms and passes away that night. How would you record the incident? Options are 1, to capture the sepsis and mortality after she passes away, so 1 CIR total, and then the second option is 1 for sepsis, and another is the CIR for her passing. And then again, if people want to make sure lines are muted, but I'll give everyone a few moments to respond. Okay, I think overall it looks like we have 94% of folks saying that we would want 1 CIR to capture that sepsis diagnosis and another CIR for her mortality. I'm going to bounce back to the presentation here. It'll take a couple seconds and the screen might flash. The next section we wanted to talk about is life-threatening illnesses or injuries. We have some examples, but obviously not limited to the following: suicide attempts, head injuries, loss of consciousness, ICU treatment, emergency surgical procedures where the likelihood of death is high. So if a person on an emergency basis goes in for the removal of an appendix, the likelihood of death is not high in that situation, although the surgical procedure is typically unanticipated. So that's probably not a reportable area unless the person has poor health. But otherwise, choking incidents, which require medical follow-up, a victim of an altercation resulting in severe injury, and then life-threatening medical diagnoses.
Will there be any more polls?
Yeah, and we will have more polls throughout.
How to vote?
Okay, so in order to vote, if you are on the web platform, you would just click the different sections to respond. There's a poll that will pop up with like a question and then 3-4 options for responses, so you would just click that box to respond. If you're strictly on the phone line, unfortunately you won't be able to participate, but we would encourage you to, internally think through how you would respond if you were able to do so. And hopefully the polls are showing up. It's on the same screen that the presentation is, so hopefully that is for you. The graph here reflects the injuries from 2011 to 2015. It's difficult to see. It's pretty shrunken down, but in the actual annual report for 2015, when that's launched on the website and then sent to providers, you'll be able to see a lot more clearly the information. But at the left is abrasion or cut, bite, bruise, burn, choking, concussion, fracture, dislocation, other, pain, puncture, sprain or strain, and then swelling or edema. And then then the far right of each of the clusters of bars on the graph show for the 2015 year the volume of each area. Okay, I do have a poll for this as well. Let me pull that up. Okay, the poll here, a couple different scenarios here, and then the responses would be for which gentleman would the scenario be reportable. The first example is Trey, who is diagnosed with pneumonia. He's 30 years old and in otherwise good health. Ronald, however, also receives a diagnosis of pneumonia. He's 75 and his health is considered to be frail. Which of those would be reportable? Trey, Ronald, or both Trey and Ronald? I'm expecting probably about like 50 responses per question, typically based on how many people responded the first time and how many different attendees are on. We'll try to look for and anticipate that many responses before we move on to the next poll question. And then in this instance, Ronald would probably be the only one that a CIR would need to be entered for. Trey has good health, so although he has that diagnosis of pneumonia, providers are really needing to know the participants best that they work with, and if you feel that due to their health, a certain diagnosis or injury is something that is life-threatening for them, then you would want to, have a conversation with the program specialist here at the division, but use, your best judgment in that regard. But typically, if someone's healthy, pneumonia would only be reportable for those who are in a more frail state of health. Do you have anything you wanted to add? Okay. All right. Let's bounce over to presentation again. Okay, in this section we are talking about types of reportable CIR still, and then this includes information on the definitions of abuse, neglect, and exploitation. Abuse, physical harm, bodily injury, also includes verbal, sexual, and psychological abuse. Neglect is a harm to a person's health or welfare. Some different examples indicated here, but otherwise failure to provide adequate food, shelter, clothing, medical care. Supports, also failure to provide necessary supports outlined in a person's plan, can be neglectful in certain circumstances. Exploitation, the wrongful taking of someone's property or exercising that control over a person. Financial exploitation is most commonly what we see in this area. And then providers are required to report all abuse, neglect, and exploitation allegations. Okay. The mandatory reporting, there's a codified law that requires the reporting of abuse, neglect, or exploitation allegations to be made to the State's Attorney's Office, DSS, Department of Social Services, or to law enforcement. Those reports to meet mandatory reporting requirements need to be made within 24 hours. A mandated reporter who knowingly fails to make the required report may be guilty of a Class 1 misdemeanor. And there's contact information identified, and then also some information on reporting in tribal communities, and those sections were taken from DSS mandatory reporting booklet. If you have any questions about mandatory reporting, you can contact Kathy Lindquist, who is the program specialist at the Department of Social Services for Adult Services and Aging. Investigation requirements. Provider policies must include a procedure for an internal investigation. There's timelines for the initiation, the issuance of preliminary investigation findings, and then final findings. that are required to be outlined in the procedure. It needs to be a procedure for remediation to ensure health and safety of participants, and also for disciplinary action to be taken if there is abuse, neglect, or exploitation that is substantiated through the investigation. Retaliation against any whistleblower, which would be the parent, guardian, other staff person, advocate, etc., is forbidden and needs to be reflected in a policy as well. The administrative rule is cited at the bottom left so that people can reference that if you have more questions or want some clarification on investigation requirements. The notification requirements continue. Provider policies must include the procedure to notify within 24 hours an allegation for the guardian, parent, and advocate, parent if the participant is under 18, unless any of those people are the alleged accused person of committing the abuse and neglect towards the participant. Then upon substantiation, investigation findings need to be sent to the parties outlined on the slide here, including the participant. Documentation needs to be found on the actions that are implemented to reduce the likelihood and prevention of repeated incidents of A&E for participants. Then the administrative rule that aligns with that is located on the bottom as well. We are hoping to have a webinar presentation in the near future here that can help with investigations, and more to be found on the next slide as well. The procedure for A&E participant training needs to be outlined, and the training needs to occur upon admission annually thereafter. That needs to be specific as far as the date, time, and content of the training. Training needs to be provided in an accessible format, which can include visuals. Participants may be more receptive to information when it's presented in an oral format versus reading off of a piece of paper what they need to learn about A&E, especially if the participant's unable to read or maybe not read at the level that the document is written. We want to make sure that other options are explored for presenting that A&E training. It might also include multiple sessions of learning the information, not just a one-time, here's your rights as a person and here's how to report A&E. It might take some repetition in that training, and that's something that teams would need to identify and plan for. Also would be the grievance information, what actions parties might take when they're not exactly satisfied with the action taken or the outcome. And there's the administrative rule on provider policy on A&E. So in the near future here, we are going to be launching a web address where participants, peers, families, or guardians can self-report allegations of abuse and neglect to the division. Sometimes that is an option for folks. They right now currently have the option of reporting directly to the division as well, and that information needs to be in training for the A&E to the participant. But we also are anticipating that might be another avenue for people to report A&E. And then towards the latter part of the presentation, I'll have more information on how that flows, like a flow chart, I guess, to explain how A&E reporting works with multiple providers, and also when the division is receiving those calls or that information through the website. But no expected date on that at this point in time, but just something that now with our new web platform we will be able to make happen. And then I actually have a poll question related to A&E training. I'm going to get that posted right now. And then there's still one person who does not have their line muted. I think we heard a door opening just now and shutting, so let's just make sure that that line gets muted also. Okay, this question here asks, how often are providers required to provide training to participants on abuse, neglect, or exploitation based on administrative rule? Options are training is provided each year at ISP meetings, Second option, A&E training is provided once a person begins receiving services at a provider. And another option, training on A&E is provided both initially and annually. Okay, overwhelmingly, it appears that A&E training is provided to participants both initially and annually. Very good. Hop back to the presentation here. The state collaborates with the Medicaid Fraud Control Unit, and so this slide is more information about Medicaid fraud. We call it MFCU. MFCU calls themselves MFUCU. I have a hard time saying that. So the Medicaid fraud, we do collaborate very closely with them. Medicaid fraud reviews 3 types of cases, which include billing issues, A&E, and failure of care, what we refer to as neglect. And this is only for those people whose supports are being paid through Medicaid. So allegations of A&E against staff, A&E between participants supported by providers, exploitation allegations, and then social media, texting, photographs, what we would consider that misuse of media. Those types of situations are reportable to Medicaid fraud. Unexplained injuries, injuries sustained as a result of physical restraint, and also mortality reports where a death was not anticipated. All of those reports get sent to Medicaid fraud by the division when we receive those. Paul Kramer, his contact information appears at the bottom left there, and then the phone number for his office. Lorna would answer the call if anyone is calling him directly. But Medicaid fraud is always willing to, like I said, partner with the division, make sure that all due investigation takes place on any of those above reported incidents. Sometimes law enforcement, they're overtapped, and they're not able to give the attention that's necessary to a certain type of allegation initially, and Medicaid fraud can have a conversation with those officers if necessary, or they can do their own investigation, or they can work with us while we conduct an investigation also. Medicaid fraud is always careful not to step on toes, so they might not request information until after law enforcement entity completes their investigation, and then final reports come across Medicaid fraud's desks, or they maybe have noticed a trend. And so sometimes when Medicaid fraud does get involved, they might be asking for information a couple months down the line after an incident was already submitted, and that's just kind of an explanation of why that can sometimes be the case. We are actually excited to collaborate with the state's attorney's office in 2017 to provide some basic investigatory training and some more intense training for program specialists at the division in relation to conducting investigations. So that's something that we're working with the state's attorney's office right now on, and hopefully we'll have some information in the near future on that type of training. And again, the division is the one that reports all of the outlined types of critical incident reports to Medicaid fraud. Providers won't be reporting those directly to them, but again, Paul is willing to answer questions that you might have. That's why I included his contact information. As we continue talking about A&E, SMART data, I'm sure people have heard us talk about that many different times. I pulled the data for 2015 for the 2015 CIR annual report, and the information appears here in the table in relation to the CIR areas that we look at. A&E reporting, which is the reporting of A&E timely to the division, to necessary parties. A&E response, which would be that investigation piece, the findings, any type of response to an allegation, and then other critical events. That's any type of CIR other than those A&E types are outlined here. We have the totals column here, the total applicable files out of those, then the number's incorrect, percent incorrect, the number correct, and the percent correct. Ultimately, the goal for what we're reaching for, working with CMS, Centers for Medicaid, the percent correct should be at or higher than 86%. And so we can see here that we're not really attaining those in all areas, although we are pretty close with other critical events. So this information is looked at the monthly SMART file reviews that are conducted. Program specialists are looking at that information. And then also every 2 years during policy implementation reviews, we are reviewing timeliness of CIRs and the CIR response and such. And then after the policy implementation reviews are done, then a plan of enhancement is drafted so that any areas not meeting those criteria for percent correct are, there's procedures and plans put into place to help try to meet that in the future. I did also pull the data for SMART, A&E reporting, response, and other critical events on the chart at the bottom right, and I broke those down by quarter throughout 2015 so that we can see how the change over time, how everything panned out there. The report function, reporting function in SMART is very helpful. It can help each organization review trends and then also compare their own organizational findings to the statewide data based on the different time frames and causal factors selected. So I know we preached that again and again to use that reporting function, but it is truly valuable, and we encourage you all to do that. And if you're a person who doesn't necessarily have the access to SMART to do that, I think visiting with your supervisor about looking at that information would be advantageous as well. In 2015, we did have some significant events. There was one CSP placed on probation related to noncompliance of several rules within ARSD, resulted in the mortality of a participant by suicide. Some information outlined here was that they had a behavior support plan. Supports were not followed, but we worked on developing a comprehensive plan of correction to remediate each of the finding areas and ensure those issues were remediated throughout the organization. Then law enforcement and Medicaid fraud were involved in that situation as well. Then there was another CSP required to complete a plan of enhancement but retain that certification status in relation to several rules within ARSD that they were found to be non-compliant with, and that situation was discovered as a result of a monthly SMART file review. But really good news, both organizations completed their plans and then maintained those maintain that good standing after reaching that resolution in 2016. But again, that critical incident report data, SMART data, and even the personal outcomes data was very valuable in these situations to help reach that resolution. Some other types of reportable CIRs, changes in health or behavior jeopardizing services, and pretty much every time I hear jeopardizing services, I picture the little Jeopardy or hear the little song in my head. So that's why I included the Jeopardy icon here. But what we're looking at in the jeopardizing services category is actually fairly serious situations. There are situations where due to change, the person's future is put into jeopardy within their service life. Let's see, the severe altercations, inappropriate sexual contact, severe self-injury, psychiatric stays, increase in behavioral issues, and increased health care supports would qualify for jeopardizing services. Also on the slide, we included information on missing persons, which AWOL is, I think, how it at least was referred to in the past in certain reporting systems. Missing persons is what we typically refer to it as. If a person has a missing persons plan or a protocol, and then that said plan was followed, then the incident might not be reportable except in unusual circumstances or extreme situations such as severe cold weather or something like that. So I have a interaction opportunity here I will pull up as well. see if this is the one. Perfect. Okay, Missy was at the mall along with 2 other participants from a provider. Missy sees the lights of the arcade and takes off while the DSP is assisting others in the store. Missy is located within 5 minutes, but she has no unsupervised time in her plan. Would this situation be reportable as a CIR for missing persons, as she had no missing persons protocol? Or since she was only gone 5 minutes, would that not be a CIR? Or are you unsure or need more information? All right, we have some questions.
No.
Oh, we don't have questions here. Oh, if you mark that unsure box because maybe you need more information, feel free to type into that chat box the questions that you might have. Otherwise, it was that 59% of folks chose a reportable CIR for Missy as a missing person because she has no missing persons protocol in place and has no unsupervised time. And that would be correct, that even though she was only gone for 5 minutes, she still was out of sight, unsupervised by the staff that were along with her. And so in this situation, it likely would not be neglectful. It probably, could have that discussion, but in some situations it might. But here it would be a missing persons report, though, for her. And again, if you have questions, we have 9 folks unsure, so either it's unsure or maybe you need more information too. So if you do, feel free to jot that down into the chat box. Okay, I'm going to get back to the presentation. Here we have information on serious medication errors and then illnesses or injuries resulting from unsafe or unsanitary conditions.
Some presenting features are available through the service activities.
Hopefully everyone's not seeing the slide. If you're not seeing the slide, let us know. Hopefully there's like a little orange bar kind of running across the bottom of it, and it has serious medication errors towards the top. So just let us know if you're not getting it. A medication error involving the administration of a provider to a participant, a medication that results in emergency medical treatment, hospitalization, or death is reportable. Those would typically be very serious medication errors with that health concern. Typical medication errors are not reportable here. Those are tracked by the organization and reviewed every 2 years.
We have 2 people not being able to see it.
Okay, so 2 people are not able to see the presentation here. Let's see.
Some presenting features are unavailable due to server connectivity issues. There's a lot of people saying that they can't. That's the message I'm getting.
Let's try it again here.
There's everybody.
I see that.
Okay.
Someone can see it. Okay. Hopefully we're able to now see the slides. Are you able to see it over there? No? Okay, well, there are folks who are able to see the messages, right? To see the slides? Okay. Okay.
There's a lot of people saying they can't.
Okay. Well, maybe it'll come back on when we're jumping between the slide and the questions. So I'll continue with that, and then if we still see some issues,
can you go to a poll question just for a quick slide? Because when you had a poll question,
I did that a minute ago here. Okay, I will go to the poll question. So don't respond to the poll yet. Okay. So then we're going to go back to the presentation. I have the presentation back up here. Okay. Well, fortunately, we sent out the handouts yesterday with that information, so hopefully you can follow along with your printed materials then, and hopefully it'll come back up too. But I'll read through each of the areas here. Routine medication errors are tracked by organizations and reviewed every 2 years by the division during policy implementation reviews. So really what we're capturing here are those serious medication errors, not those of a routine nature. Then missing medications, which are typically controlled substances or stimulants, would be reported under the victim of theft or exploitation categories, depending on the circumstances, not as a serious medication error for CIR purposes. I have a couple different polls for this section, so hopefully we'll be able to see those. We'll have 3.
The polls are coming up.
Polls are coming up, okay. I'll have several of those here. This one, Brian went on a trip out of state. The trip was planned, and he was accompanied by staff. While on the trip, Brian did not receive any medication as the DSP forgot to bring them along. Is this reportable as a serious medication error? Answers are yes, no, yes, and it might also be considered an allegation of neglect, or you're unsure. Correct that the 91% say that, yes, it's a medication error, and it would be an allegation of neglect. I think the other section of our question might have gotten cut off here. In this case, it would actually, not given the information here, I understand how this would be hard to respond to, but there was some serious health concerns that he had as a result of this instance, and he did end up being hospitalized. So it looks like that is cut off of the tail end of our questions here. If he had suffered no health concerns, then it would not be reportable. I have a couple more options. Hopefully all of those, the whole question appears here. Okay, Nora was administered another participant's medications, and she ended up having a seizure which necessitated a trip to the ER. Is this reportable as a serious medication error? Yes or no? All right, correct. That 55% show, or 100%, 57 people responding indicate that it would be a serious medication error. And then here, yes, we're able to capture the health ramifications that were suffered because of that medication error with her entering the emergency room. I have one more question here that I want to pull up. Oh, not that one. Okay, here we go. Chad's hydrocodone containing 13, card containing 13 tabs was not in his medication box this morning. How would that be reported? The options are that that's not reportable. The other option is as a serious medication error, or that it should be entered for the victim of theft category or exploitation, depending on the circumstances. And of course here, he had not received any inaccurate dosages, and so he had no health concerns given the issues with his medication. But we do often see attempts to report missing medications in the serious med error section, whereas correct, 100% of people responding would agree that it would be either a victim of theft or exploitation, again, depending on the circumstances. We would have to probably have a conversation because it is a little touchy to try to figure out which of the two options it could be. All right, let's get back to the presentation. I'm hopeful it works this time. We're going to try something else with the permissions here too. Everyone is on the permissions. Oh, that's just for downloading. Okay, we're presenting it now. Okay, we're at the beginning, but that is promising. That's good news. I will jump ahead here to slide 16 is, we're up 15 is where we're at actually. Okay, the other portion of the slide is illnesses or injuries resulting from unsafe or unsanitary conditions. Illnesses such as salmonella, injuries, fractures, dislocations, unexplained injuries resulting from unsafe or unsanitary conditions are reportable. I have a couple different scenarios here as well. Let's try this one. It appears that I lost my titles for some of these. No, not this one. Here we go. Tony slipped on the ice outside of his group home and fractured his pelvis. Is this reportable as a critical incident report? Options: no, it's pretty slick out, which indeed it is. Or yes, this would be considered an unsafe condition. Or the option of yes, because Tony's plan also states that staff should be walking alongside him when navigating ice, so that might also be considered neglect. It's kind of a tricky question there in the responses. All right, looks like 79% of respondents agree that it would be reportable because of the setting, but also that it might be neglect because the staff are indicated in the plan to be accompanying Tony while walking on ice. It should be potentially considered neglectful as well.
Wait, what is it?
then we have one more poll related to this question. Here we go. Goldie was at a local restaurant and slipped on a wet floor, fracturing her elbow. Is this reportable as a CIR? Options are yes, it was an unsafe condition at a restaurant, no, because it's not a provider location, or if you are unsure. All right, there's a question. The question doesn't specify if someone is supposed to be helping them or not. This is just Goldie. She lives in a level 3 setting. She has unlimited community time, and just thought she would venture to the local pizza ranch on her own, like she typically does every Thursday afternoon, and she slipped and fell on their wet floor. I don't know if that changes the responses any, but thank you for asking for some additional information. Changes it a little bit. It's not so neck and neck anymore. That's that's good. I started to question myself for a second here. But really what we are looking for is that the 54% to agree that, it's not a provider location. Goldie is on unsupervised time. It would not be reportable. And we do often get many reports of people slipping and falling, whether floors or ice, etc., at a community setting. This would be an unsafe or unsanitary condition that a provider has control over, and so that's really the tipping point here with the question here. So no, it's not a provider location, or she wasn't supervised during that time, so it would not be reportable. Okay, going back to the presentation here. Fingers crossed again. Yay, okay. The next slide here that we're looking at, there we go, is types of reportable CIRs. These deal with illegal activity and law enforcement involvement.
Going back to the other poll,
okay.
There's another question.
Yeah.
Would you have needed to report a CIR if Goldie had gone to the ER?
Either way, if she went to the ER, it might be reportable. In the other area, if she had like a life-threatening type of surgery injury, but typically if it's, I think it was just a fractured elbow in this scenario, likely not reportable as a critical incident report. Certainly something to report within your provider organizations and to having the quarterly monitoring and captured in that information, but it would not be a CIR for the injury, even if she did go to the ER. If she had slipped and fallen on a wet floor in a group home, then yes, it would have been. So I think the setting is the key here, not the next steps as far as medical treatment. But if she slipped and fell and there was no problems, then she slipped and like, oops, whoopsie daisy, then got right back up, nothing, no injuries, then it would not be reportable either. Okay. All right. So back to illegal activity of law enforcement involvement. This is really where the participant is the alleged perpetrator of a crime, and then law enforcement must be involved here. I walked through, in case you're not a fan of the polls, I did not do 6 different polls here on this slide. Hopefully people are a fan of the polls, but just in case, I thought it might be more succinct to put that in here. So for reportable scenarios, Stan receives a citation for a DUI and must appear in court. Lance became involved in a bar fight and is charged with assault. And Melissa was caught shoplifting, and the shopping mall called the police, and she has been charged for the offense. Ways that those 3 might not be reportable is if Melissa was caught shoplifting, and actually it happens fairly often actually where the the shopping center is like, okay, well, you know, it's not a big deal, just don't let it happen again, or just banning a person from that shopping center, that's a way that that would not be reportable. Or if Lance was in a bar fight, but there was no impending charges as a result of that. Some not reportable scenarios, Stacy was cited for exceeding the speed limit and has an $89 fine. Not a serious crime, that's really outside of what we're trying to capture here. Another way that incident reports might not be reportable is that Mark's the participant, Mark's girlfriend, who is non-supported by the organization, she wrote one of his checks for $1,000 and is charged with theft and forgery. Again, the participant is not the alleged perpetrator here. So it wouldn't be illegal activity for Mark. It might be exploitation, but not, or victim of theft, but he would not have a CIR for actually committing any illegal activity. Hopefully that can help identify a little bit what is and isn't reportable, because the victims are not reportable, at least in this category.
We're getting a couple of messages that they're not seeing the next slide. So is there any way that you could go back to the poll and remove the...
We can do that again. You know, I knew we were taking a little bit of a risk with this poll, but I really thought that they were going to work. I was confident.
Just right now they're stuck on the mid-air slide.
Okay. So we went back to the poll. Hopefully people can see here the wet floor with Goldie. And now I'm going to go back to the presentation again. Loading. Do we see that?
Got it. Yep.
Yay, okay. What a relief. Oh, okay. And then another scenario here is where Gina's case manager was doing an observation and she found marijuana in Gina's apartment during that observation. In this case, there was no police involvement. The case manager didn't contact the police. You know, Gina was just advised that the information or the paraphernalia and the drugs that she had were illegal, and there were no actual police involvement and no charges filed for her. So that's why in this scenario it is not reportable. I might hover on this slide for a couple moments just so folks can read the information, since it might not have been up for everyone right away. But really the key to identifying the illegal activity as a reportable CIR is just that the person must be the one accused of committing a crime, and there must be actual law enforcement involvement where charges are pressed.
John says the slides are not changing at all either. And there's about 3 others saying that they're still stuck on the mid-air slide.
Oh my goodness. Okay. Do we see illegal activity now?
Yes, Liz. New horizons of no. I'm getting out more no's.
Interesting.
Somehow the poll and rebooting. But a lot of people are saying it too. So
okay. Well,
I want to research them and look at their paper copy.
Yeah, I think that paper copy would be helpful to refer to. We'll, we don't really have any more polls for, oh yeah, we do. We have one more polling opportunity, and then we don't for a period of time. So if we can't get it back after that next poll, then I will start again from the beginning before we get into the therapy section. Here on this graph, or in this slide, what I have is a graph at the top left which captures the 2015 illegal activity, and this is a brand new item in the 2015 CIR report, whereas we did that statewide comparison of mortalities for the 2014 report. This is brand new for the 2015 report. On the exterior circle, we have the statewide data for crimes. We had put them into categories which include illegal, drug, misuse of media, other property damage, theft, assault, disorderly conduct, disturbance, and trespassing. And then on the interior circle, we have the CSP data for those same categories. And again, all this information is also in the annual report. So if you're not able to see the slide today, it's in the PowerPoint that has been sent and can be sent out again. And then also in that report, which should be published to the website and sent out to providers soon. In the slide to the right, or the graph to the right, the CSP CIR illegal activity data for 2015, for multiple years actually, year ending in 2015 in that time range. You can show actually decreasing over time from 2011 to 2015. And then the table at the bottom includes the information that is captured in that donut graph. Types of physical, mechanical, chemical intervention, highly restrictive techniques, highly restrictive measures, whichever you want to refer to them as. A CIR is required if a restraint is used without due process. And again, I'm reading each of the different words on the slide here just for the folks who aren't able to see them. If a restraint is done incorrectly, which would be not per plan, it is still reportable. And then when it's utilized for an emergency situation to ensure safety, a CIR is reportable if it's not written into the plan prior to use. A way to explain that would be an emergency rights restriction for a person who is refusing to leave during a fire. We would expect staff to physically assist that person out of the unsafe area, even though it would result in a CIR. But it would be, logical and what would be necessary to ensure health and safety for that person. But we still want to capture that information here. The administrative rules included, which include the different sections for highly restrictive procedures, policy for highly restrictive procedures, the prohibition of restraint, prone restraint, timeout, and chemical intervention. There has been a recent update to timeout, so you might want to take a look at that. And then people also need to ensure that the emergency rights restriction administrative rule is followed as well when there are those types of emergency situations that are necessary to be followed. Let's see, I have, I believe, a poll question here. Let me get that up here. Yeah, I have a message actually. Pam, you all are muted. We had a difficult time getting folks to mute all of their lines. We had a lot of background noise, and so we did mute all lines. If you want, if you want to tell me your phone number, I can unmute that specific line. If, oops, no, I need to advance slides here. I'm just trying to get the participants opened up here. And then I can also unmute your device as well. Or if you want to type your question into the chat box, might be effective also. I think we'll get that poll up and running here in the meantime. I do apologize for that inconvenience. It's always difficult when you have background noise to continue with the presentation. Let's see here. Okay, the poll here, there's a couple different options here, and then options for the responses. So the scenarios are actually in the question. So what you are going to want to respond is if which of these are reportable CIRs, and you can only select one option with this polling question, and so that's why we created that question the way that I had. So A, Eve ran towards the street and staff bear hugged her to stop her. The bear hug's not in her plan. B, Tim has a BSP or behavior support plan which includes hands down, during an incident, and an escort technique was used, not in the plan. So hands down was in the plan, but the escort was not. Then also C, Gina was administered a PRN of Ativan per her protocol. So which of those three would be reportable? All right, we're showing 41 responses so far. That's pretty clear that folks believe that A and B are reportable. Gina's PRN that was administered was done so per protocol or plan, and so that's why it's not reportable. Okay, I'm really hoping that the presentation is able to come up this time here. Technology. Okay. I have it up on my screen here. Hopefully people are able to see this here. I'm going to advance to a slide that has bruise or injury resulting from physical, mechanical, or chemical intervention at the top. Are people able to see this slide? If not, I think this is the last, that was the last poll, at least for a while, and so if not, I can start the presentation again from the beginning. If you want, Beth, are you able to see it?
Yeah.
Okay, good deal.
And we have yes and no's. If you need the PowerPoint, please send your email via chat, and I'll send the PowerPoint to you.
Perfect. Okay. So what we're looking at here in this slide is any bruise, injury, or death which is a result of a highly restrictive measure that's also reportable as a CIR. Medicaid fraud is notified of these instances. All appropriate parties must be notified by the provider. Then, as always, if A&E is suspected, mandatory reporting must apply. Some people do bruise more easily than others, so reports of bruises during restraints may occur, and even in those scenarios, they still remain reportable. And then always rings or other jewelry worn by staff may cause scratches or bruises at times, which are also still reportable. Those were a couple questions that were raised while I was forming this presentation, so I thought I would include that information here. Diagnosed communicable diseases that fall on the reportable diseases category are reportable. There are several attachments here to, I have a little error message now. There are several attachments on the PowerPoint, or on the Skype platform here, and I believe you can access those at the bottom of the screen, but one of them does include this reportable diseases sheet, which I had a little bit of a screenshot kind of here to the right of the slide. Typically, this is updated in the beginning part of each year, and so it's anticipated that the division nurses will send out an updated version in January. Any communicable disease listed under the Department of Health administrative rule would be reportable to the division, and it needs to be a diagnosed version of having this disease. An example would be that if there's a group home where one or two participants go into the physician and are diagnosed with having influenza, but then the prescribing physician might prescribe medications for the other 5 or 6 people living in that home as more of a preventative measure, or that they are assuming possibly that the other people in the home would have the same type of communicable disease. It's actually only reportable for the 2 that it was confirmed for. So it needs to be confirmed or diagnosed reportable communicable diseases. Cassie, do you want me to talk about the MRSA piece here? I sure can. Okay, perfect. If MRSA bacteria penetrates deeper inside your body or into your blood, it can cause a more serious or invasive infection. There are signs of an invasive infection which appear on the screen here, and MRSA is only reportable when it is in the blood. Okay, we're just like, is that right? Okay. Otherwise, it's early to trend information, but there might be an increase in sexually transmitted diseases, and that also, of course, would align with statewide trending. And again, at the bottom part of the website or this page appears the website where you can find the reportable diseases link. It's on the attachment to this PowerPoint as well. Next slide here, maybe. There we go. Types of reportable CIRs. This refers to alleged instances of corporal punishment, seclusion, denial of food, or other practices. Corporal punishment, physical or verbal abuse, such as shaking, screaming, swearing, name-calling, or any other activity that would be damaging to a person's well-being or self-respect. Seclusion, placement of a person alone in a room or other area where egress is prevented, except utilized by certain settings with applicable rules followed. And then denial of food, which is preventing a person from having access to a nutritionally adequate diet as a means of modifying behavior. This is actually a new addition to the CIR guidelines, an administrative rule, which includes specifically corporal punishment, seclusion, denial of food, and similar practices. Those are reportable as CIRs. A&E may also be reportable categories that would align with this, and of course, mandatory reporting always applies. At the bottom, it also says any other critical incident as required by the division. So any verbal report that comes in that doesn't necessarily align with any of these 11 categories so far, as this is the 12th, that would be deemed reportable, would likely be, but there's always a conversation about that information here. Okay, any questions about the guidelines? That really wraps up that piece of the presentation. Next, we'll discuss the TheraP transition. Go. And so I'll maybe wait a couple seconds here. If people want to type into the chat box, they can do so.
I'm sending a lot of them the PowerPoint.
Okay.
Benchmark, one person requested the PowerPoint and is going to forward it to all Benchmark staff.
Great, thank you. Ambassador, such a trooper for keeping track of all of these, the communication here. Okay, well then we'll begin with TheraP, and then Leah, are you still on the line? I hope.
I am. Can you hear me now?
Yes, we can. Very good. Thank you for being on the line here today. And so folks who are here, if there's any questions that you have related to the transition to TheraP, now it's an opportunity to ask them. Maybe we'll walk through this a little bit, and then if there's questions at the end of that section, and of course, if you have anything you want to add as we go here as well. Really just CIRs, they're being captured by providers in categories that would be similar to those that we had on the other slides with the version of the guidelines that we currently operate under. With TheraP, some of the categories will vary a bit. I wonder, that looks really hard. Maybe I should get into TheraP here, and we can look at that.
The PowerPoint's stuck.
The PowerPoint's stuck again. Oh,
yeah,
goodness.
So maybe
now's the perfect.
over the perfect time.
Okay, I'm going to present my desktop now. All right. Do you all see the CIR screen on your desktop? Or on your screen? It's loading. Okay.
Yes.
Perfect. So on the CIR website here, you can hover over the section that says States, and then I'm going to scroll down a little bit. States, and where it says South Dakota, click there, and that's where you'll find a lot of your resources that would be helpful in the authoring of critical incident reports as GERs in CIR. There we go. As I mentioned in the beginning of the presentation here, any incident occurring on or after July 1st of 2017, we would be expecting to be entered into the CIR system. That's really our cutoff for that. So any up until that time would be in Launchpad, and there is still that 7-day allowance for those written reports. So those would still be entered into Launchpad if the incident occurs prior to the 1st. But any on or after the 1st would go into CIR. Here is information on CIRs and GERs, and it really just kind of outlines, find Ariel, that's all right, outlines the procedure to enter critical incident reports, the notification section. We do want the DD staff as the administrator, even if you have people from within your own organization being the administrators. That's just the category that we are putting DD staff into. The DSS contact should be in that spot, and also law enforcement. And then even though it does allow an option to say that the division was contacted via email, we are still requiring that phone contact. So we want to just make sure that that's clear. But the report date and the event date and the written date, all that information, I'm just going to page ahead here a couple slides. We'll talk about that in a little bit here. The division will be following up on GERs. We'll be clicking that "We've reviewed this approved report" button, sending the information to Medicaid fraud, and peer reviewers, quarterly reviewers, we may still be documenting information in those sections after, oops, a drawing error has occurred, after that portion of time has passed. Once a GER is approved by a provider, it can't be edited, and it does not appear typically in our message center as at the division for review until it's approved. So that's one reason why we really want to make sure that folks are aware of what the different requirements are for different GERs, so that hopefully we don't have to have many re-entered and deleted. So if there's questions about what to enter in what category, just give us a call and we can have a conversation. The mapping document should help with that. I'm going to pull that open here. There we go, the South Dakota Instant Mapping. See if I can make it a little bit bigger. There we go. Has the different options that align with the categories. What we find at the left is the South Dakota categories from our guidelines, and then in the event category section and the SD subcategory section are some options for choices that you could enter. So let's say that there was a life-threatening illness or injury, an emergency surgical procedure where the likelihood of death is severe. You could enter that in hospital as the event category in hospital, and then the subcategory in admission. And then life-threatening, I'm trying to get my little PDF thing here to go away. Life-threatening medical diagnosis could be other, and then change of condition. For those A&E reports, there are different ways that those can be entered. Abuse, neglect, exploitation, they can be entered in different ways. So if it's, and Leah, help me out here if you don't mind if I'm saying it wrong, but for abuse, like it can be entered under physical abuse, like by the type of injury,
and then you would just select the yes for abuse section in the box, right?
Correct. It's kind of under the general section. So once the event information is submitted, whether it was an injury or something else, even hospitalization, anything like that, the abuse, neglect, and exploitation section is separate. So it could theoretically be attached to any type of event that you're documenting in a GER.
Okay, so such as the neglect for a person tripping and falling or for that medication error. Okay.
Correct.
Okay. And, you know, this document's out there so folks can reference that, and then let us know if you have any questions, especially if you're going to be providing training to others within your organization who might be entering those GERs. Now would be a really good time to look through these so that we can maybe answer some of your questions before we get to that stage where we're going live and entering information. Let's see. I'm going to go back to this page here. There is a South Dakota CIR flow chart that Therap has created for us. When a critical incident report happens, CSP or case manager notifies the program specialist. The report is written, goes through the internal review. No longer than 7 days. The GER needs to be approved by the provider. Okay, the DHS reviews the GER, adds any follow-up. Then the GER resolution must be completed within 30 days after the critical incident report was first reported. And there's a question, I understand?
Can you show how to do it on an actual GER?
I can do that. Now I'm on, I feel the pressure to try to remember my login, so, oh my goodness. Can someone sing that Jeopardy song? Not really. That's sarcasm. I think that's it. Oh.
Leah can help you out if you need me.
DDDSD. I may. Let's give this one a try. Yay! Success! And it's Friday at 4 o'clock. This is amazing. Okay, let's see if I can. Well, I don't even know if I can enter a GER. I can view, I can follow up, and I can search. I don't know if I am able to enter a CIR. A GER.
If you were to go to switch provider, you may be able to do that from the provider level. Depends on your access rights.
Okay.
But I also can walk you through how to give yourself access rights if you need it from the oversight account.
I would be, my concern right now is that I'm
DHI.
Doing that because I don't want to, reveal any participant names or anything either while I'm doing that.
Yeah.
So how would I do that?
Dashboard.
Okay, dashboard.
Well, yeah. Would you prefer that I log in? Would that help you out at all? If I logged into a demo account and you... Okay. And forgive me, I haven't used, this is my first time using Skype. We use GoToMeeting a lot. So are you able to give me controls or show my screen?
Yeah, I am. I'm trying to do that here, this section.
Are you going up to the give control?
I'm trying to actually minimize this box here that I opened up.
Go to the give control.
I need to first make, I believe I still need to first make Leah a presenter before I'm able to do that. I think. Let me try it. Oops. Okay. Let me see here. I'm going to try to just minimize this screen here. Oh, there we go. When we have it in
presentation mode here and hooked up, I have a difficult time navigating that. So I'm going to set it back to the presentation, and then I will, or I'm just going to present a poll actually, and then I'm going to make Leah a presenter here. Okay, I think I have accomplished that, Leah. Are you able to request access at the top? Now that I have that poll on there, it's not letting me do that.
Yep, I took over as a presenter. I clicked on take over,
Okay.
and we'll see if it lets me.
Then you might need to click that little television screen at the bottom, that little blue computer monitor, and then present your desktop.
Okay. Interesting. Can you see my screen at this point?
It's loading right now.
Yes, it's loading.
Yeah.
I see it. Oh, great. Yep, we can see it.
Okay, so you should see my name up here.
Yep.
Okay, so I'll open up a GER, and if you want to kind of direct me as to what you want to review with the group, or I can take over and you can chime in, whatever works best for you.
Sure. Did we want maybe to do an allegation of abuse, or did they specify what type of GER they wanted? Maybe let's do a physical injury as a result of physical abuse.
Okay. And forgive me, I haven't been on a lot of the South Dakota calls. We've kind of been divvying things up. So forgive me if I'm repeating anything that the providers in attendance are aware of. I know that Jeff has been working with a number of you. But my view in this demo account is more of the provider side. So it does look different than your oversight side of things. So I'll go to GER New, and I'm going to go to my, this is a test group home in Maine. So it has Maine-specific forms attached to it. I don't know if that'll be a problem. I won't show you those because it's not relevant.
Okay.
But we don't have a South Dakota-specific form attached to the GER right now. Is that correct?
I don't think we do right now. I think we're developing something,
Yeah.
but I don't think it's ready yet.
Yeah, that's what I was thinking. So this is one of my go-to people within this group home. And if you want to kind of, okay. So the report date, I'm just going to start from the beginning, but let me know if I'm covering things that don't need to be covered. The report date can be edited, so that could be, or typically would be, the date that the report is being made. And the event date is editable as well. So that basically allows for staff to indicate if the event happened, say, yesterday or the day before. Okay. And then you fill out this information. This is if not at responsible program. I chose this group home where Sarah resides. So if this happened elsewhere, then I could indicate that other location. Okay. To describe what happened before the event would be something like an antecedent. Okay. So we're going with the example of a hold. Is that correct?
Yeah, that's fine. And then an injury as a result of that. That works, yeah.
Okay. So I'm just going to click on famous program address and pretend that happened at the particular home. So the antecedent could be a description of what was going on in the environment, the antecedent before the event occurred. So if the person were engaging in targeted behavior or something like that. And I'm just going to keep it really simple. Maybe it was, aggression towards others or something. And then down here is where we get into the event. So I could go with the restraint related to behavior, if that were applicable.
Okay.
When you have these fields, these kind of boxes open up, you want to make sure you maximize them so that they're taking up the space in your screen. Otherwise, if you don't maximize them, you run the risk of having two boxes open and then having two scroll bars and graying out one part, which is an easy fix, but I just do this out of habit. So you've got your begin time, end time. So I can't report after right now, and I'm on East Coast time, so I'm an hour ahead of you. But it won't allow me to report after the current date and time, because I can't predict an event in CIR. This is where I apologize for not being more prepared to take over, but these fields down here, basically the restraint or the behavioral intervention is configurable at the provider level. So this is just what's specific in my demo account based on what's being used as an example within this particular state. But that is configurable based on the interventions that are approved. Okay? So I could say that were approved or emergency, whichever one occurred. If there was an injury, then I'd have to indicate yes. Whether I'm not monitoring the individual every 30 minutes after the hold, I would need to indicate that. And this is another kind of custom field based on the interventions. So is exercise being offered, or is the person engaging in exercise as a way to redirect or as part of their behavior plan? So I could indicate that. And then the restraint types are listed out here. So those are, again, based on the provider and what's approved. So that's where I would indicate, and chime in if you have any suggestions, Ashley, is kind of where you're going. I could do like a 2-arm standing restraint or something like that. And then the person's applying. Does that work for you?
Yep, that's perfect.
Okay, so the person's applying, like if I was the person applying, then I wouldn't necessarily need to fill this out, but if there was another staff member involved, or if I were reporting I was entering in the event, but someone else is actually the one that implemented the hold or the intervention, then I could indicate them there. Okay, so in charge during, so that would be the staff person that was in charge while the hold was being completed. I'm going to go with Deb, my colleague. Person removing, emergency restraint trauma check within 24 hours, and basically any protocols that were followed and who administered those protocols. And then a summary. Okay, I'm just going to keep it general. Witness, that's turned on in our demo account. And again, most providers are not using Witness, to my knowledge, simply because what happens, when you create a Witness form in CIR, it prompts the other person to have to fill out the form. So a lot of providers and states choose not to use the Witness feature. So it will tell me if I missed anything. I just kept it really straightforward. Under general information, that's the section where we choose the abuse, neglect, or exploitation. Okay, so this is completed by the person submitting the GER. However, the staff that have access, the super role access to abuse, neglect, or exploitation are the ones that are able to document that. So if there are some staff that don't have access to this, then they wouldn't see that information when it's submitted. You know, if it were marked as abuse or neglect suspected and they did not have that role assigned to them, they wouldn't have the ability to view that GER. Okay, so it's really role-based in that sense. the person submitting the GER would see this section, but then once anything here is checked off, it's based on who should have access. So what would you like me to check off in this section, Ashley?
Let's do a suspicion, or sorry, that abuse is suspected.
Okay.
Suspicion of abuse, and maybe a physical abuse there.
Okay. Okay. And what about neglect or exploitation?
I think in this case, no's. And we'd want that notification level high for folks.
Okay. So we see here when we choose no for neglect and no for exploitation, we would leave the drop downs alone, just as a side note,
Perfect.
because it wouldn't be applicable. And then reported by, so my name is at the top for entered by right here automatically because I'm logged into my account. But then reported by, I'm also going to leave my name there. But again, that SERP just allows the ability to indicate that, you know, I'm the one entering it into the system, but let's say someone that I supervised was the one that reported this to me. It gives the person entering it that ability. I hope that's clear. If not, feel free to ask any questions.
No, that aligns with what we would want. Yep.
Okay, so I'm just checking the question panel. So the reporter's relationship to individual, that would be staff in this case. And that sums up the abuse, neglect, exploitation area of the GER. And then we would get into the notifications.
Okay. And then here, I mean, I think that's probably pretty straightforward since we're kind of running on short on time, but just adding the notification information, like I said, the DD is the administrator. If you have your own internal administrators, DSS, all that would be entered here.
Okay. And are you using the other field if the labels don't match up?
Yeah,
it's all on the mapping document. Okay.
Yeah, or just encouraging, you know, the best alignment with what it would be.
Okay. And as we reviewed in the email, like you mentioned, if there's two administrators being notified, the internal and the external at the state level, I can still add another notification info and indicate someone else as the person that I'm notifying as an administrator. So I can still go in and add more people as appropriate. Okay. And then for actions taken or planned, corrective actions taken, the way that we view that is well, of course, it's always up to the state or the oversight, you know, body to indicate that in guidelines. But generally speaking, the corrective actions taken is really where the staff would indicate what supports were provided to the individual to address this situation. So I would say, how was the individual supported, or what was done to follow up in the moment itself. Does that make sense?
Yeah.
And then future corrective actions could be a way to document how this could be prevented from occurring in the future. Okay. And then these, go ahead.
I was like, can you explain, or actually maybe I'll wait till you finish that section, but I just wanted to know about that piece that it's like an addendum where people can do the investigatory response, and I can't recall what that's called right now.
The resolution, GER resolution?
Yes.
Sure. So that will be largely based on your roles, of course. So essentially when I'm submitting the GER, this would be the point where I leave off, and then this is all kind of the follow-up. So saving it keeps it in draft, submitting it moves it forward, and then approving it moves it even further forward. Okay, so I'm going to submit that. And it's giving me guidance around things that I didn't complete based on the provider preferences. Like this whole section, I didn't adhere to that because it's labeled high. So I'm just going to try to override that by clicking on submit. And yeah, it won't let me. All right, so this would typically, we would want to leave this high, but just to move forward, I'm going to mark that as low, so it'll let me move forward, which is good. You know, basically it's offering guidance and it's setting up perimeters, saying that this is a high-level GER, therefore these people need to be notified.
Perfect.
And it's also wanting me to fill out the main state form. Okay, so.
Well, we could even walk through the rest of how.
Yeah, we'll do that. We'll just skip over. So basically, we should go over resolution is what you'd like to do, correct?
Yeah.
To do an investigation. Okay, so if there is a GER that needs to be investigated, such as the one that was marked as abuse or neglect or exploitation, then I would go in and I could look at unaddressed GERs, or I could do a search. So I'm going to do unaddressed. And it's going to show me those ones where there has not been an investigation done yet. So I could open this one on Ralph Angel. I didn't get to submit the one that I just did. So I'm going to open this one up and complete the resolution, which, again, is really just documenting the investigation itself. So date open, date closed, the status, whether it was a critical event, if an investigation is needed, what type of abuse, neglect, or exploitation it falls under. So with the one that we were previously looking at, that was physical abuse. And then the findings and involved persons, so I would type that in. Okay, so if I was the one that inflicted, which hopefully that would never be the case, or not hopefully, definitely that would never be the case. So then my title, the involvement type. So if I was the perpetrator, then I would indicate that there. If it were the victim that I was documenting in this line, then I would indicate that there, etc. The coordinator, investigator, and witness are all selections from that drop down. And any comments. And then the details of the investigation. So the narrative, any notes, any staff actions that were implemented or discovered through the investigation. And then the recommended by, date recommended, person responsible, completed, and recommendations. I'm using Google Chrome, so I can click and drag this box, but if you're using a different web browser, such as Internet Explorer or Mozilla Firefox, anything, the boxes may turn on differently, but basically that scale will expand as you type, and I think with IE, the box will be a little bit bigger, but it will allow up to 3,000 characters for the recommendations. All of these boxes up here allows up to 10,000 characters, which is a pretty large text field. It works out to be, I know 3,000 characters is about 3 pages of a Word doc. So it's at least, at least 9+ pages of a Word doc you could potentially put into these boxes. So they look small, but they will expand. You have the ability to attach supporting documents. I'm sorry, go ahead.
No, I said that's great.
Okay. And then supporting documents as attachments, a maximum of 10 megabytes. And then there's another 3,000 characters for closing comments. And then the add piece. So I would click on add when I was adding those comments, and then I would save.
Okay. Awesome. Thank you so much. We have about 10 minutes left, and I have a little bit more I wanted to try to get through. So I think if we're having other questions with how to enter the GERs, that if you want to feed us those questions, my contact information is at the end of the presentation, then we can get with Sarah. Colin and I are going to be having, I think, weekly meetings or bi-weekly meetings with Jeff Covington from Thera as we move forward with the implementation here, and so we can always, have those conversations with them about that. Okay. I am going to try to see if I can present that PowerPoint again here. And thank you, Leah. Sorry if I started moving us along here. And such.
Oh, no problem.
Shanna Bierman, Volunteers of America, has participated in a pilot to have GERs as CIRs as GERs in TheraP, and I'll update Leah's contact information here too in the future here when I send the PowerPoint out again. But Shanna, I don't know if you're able to be on the line here since I muted everyone, but hopefully we got you unmuted. If you just wanted to, if you had anything you wanted to mention, I'll work through the working and not working from what we've discovered based on the pilot here briefly. But just for current therapy users, it's a familiar system. It's easy to track what information is entered. You can see who's read the GERs. The folks who are familiar with therapy feel it's easier to navigate versus our Launchpad. And of course, they found that centralizing the entering of those CIRs as GERs to one or two people has been helpful. We have had delays in accessing accounts. We also had experience that you couldn't have two TheraP accounts open at the same time for copying and pasting, like from a CIR that was written by a DSP into one that was written by or needs to be written by that oversight person, but that has been solved, Shanna mentioned, by using two browsers, Internet Explorer and Chrome. The division review is different compared to the Launchpad. People are still adjusting to the new format. The report date, it was mentioned, why would we need that? Need to change that report date to be the same as the notification date, but for reporting purposes, we would want that to be the case. The current procedure is to use a CSP admin, and then also now we're wanting the DD to be admin, and that's still okay that both entities are admin in the reporting or notification section. And then the division is not receiving emails like we did in Launchpad, so it's a learning curve for us trying to get in and look at those GERs when they're entered. And then Leah, Shanna mentioned that approved reports are still showing up in the follow-up sections for CSPs, even though there's no action required by that CSP. Would you be able to explain that at all, or do you know anything about that? If not, we can follow up in the future, too.
Yeah, my first thought when I saw your email this morning was that they have the follow-up role assigned to them, then they'll have that prompt on the to-do tab of their first page or dashboard. So it's really based on that. So even if they aren't responsible necessarily for follow-up, but it's assigned to them in TheraP, that would be listed there. If you have a specific example of that, though, if you're able to send us through My Issues, the Form ID, and let us know the user that is experiencing the issue, that would be the best way for us to investigate it. It's also the secure way for us to look into it. So My Issues is at the top of either the dashboard or the first page, and then the Form ID is at the top of the GER, and then the user, meaning the staff, their full name, and we can look and see what's going on and look at their roles and the status of the GER, et cetera.
Okay, great. And then Shanna, VOA had mentioned that referencing multiple documents to learn how to enter the CIRs and GERs is a bit difficult at this time. But hopefully as folks get to know how to enter those a little bit better, it'll be a little more seamless. You won't have to flip maybe from paper to paper. Shanna, is there anything you wanted to mention, or could you maybe just give a brief overview of how everything has gone for you during the pilot? If we're able to hear you. if you wanted to type it in the chat box, Beth said she'd read it out loud for us too. And I should also mention that I know it's getting to be about 4:30, which is quitting time for some folks. And so, like I said, we are recording this presentation, so if anyone does need to leave, we will wrap up here though still, even though it's exceeding our time frames a bit. But it's being recorded, and again, we have that PowerPoint sent out. So if people do need to leave, that is fine.
Shanna says she doesn't really have much beyond what was on the list.
Okay. Well, sorry to steal your thunder too, Shanna. I'm sorry about that. I just wanted to walk through what was on the working, not working. But we do appreciate you all being willing to go through the pilot of entering those GERs into CIR, so we could experience how that worked a bit. Okay. The next slide then that we're going to go to is that reporting time frames here, and this applies to all critical incident reports, but I wanted to hit on it after we talked about CIR, so that we, it would make a little bit more sense with the date for the reports and such. So your verbal report is required to be done within 24 hours or the next working day of an incident occurring. And that does differ, again, from that mandatory reporting, which is specifically 24 hours. So for that mandatory reporting, if it's a weekend and there's an allegation of abuse, the Department of Social Services is closed, so you would need to contact law enforcement. But for your verbal report to the division, it's 24 hours or the next working day. And so if an incident occurs Friday evening at 7 o'clock, you would give us a call on Monday morning to make that verbal report. And then the written report is 7 calendar days from that verbal date. We've had lots of questions recently, I think, with new folks entering CIRs and how the written date aligns with that verbal date. So this is the best way with the little calendar here at the bottom right to explain how that translates. So you have your verbal report occurring on the 13th, for example, and then you have those 7 days, and that's your written report due date on the 20th. Follow-up is requested by the division in many instances. Now with CIR, once we transition to that, follow-up will be requested via SCOM, which is a secure communication, the CIR email process to the provider if there's information requested in kind of that time frame typically that we would expect that in. Right now, we would just, it would trigger an email if we need to send a request for follow-up. Okay. Here's the CIR annual report. This is what the cover of it looks like. We did send in the recent history here, a survey to providers to see how people are using it and how we can apply the annual report usage. With the new 2015 report that will be launched here shortly, the format has changed significantly to be more user-friendly and readable, maybe. The 2015 report is also shorter, but we feel with even more data. And then 2015 was also the 10th annual report, so it was neat to see some of those trends over a 10-year span of time. SMART, NCI, and CQL information has also been incorporated into the report. And then next year, we are going to be pulling CQL, personnel outcomes data, into the report as well. I'll really just kind of jump through these slides rather quickly here, but we have the number of incidents from 2006 to 2015. The total incident count is that second, middle color of teal here. This graph appears, it's a full page. I joke that it should be like a centerfold in the annual report. It should be a nice giant-sized page, but it's just a typical one page, but it's sideways. So you can really see the graph a little bit more, and it's actually in some different coloring now, too. I understand Beth has made that change for us, and so it's much more readable here than what's here as well.
There's more specific data on some of the graphs.
Cool.
As well below.
Awesome.
Great.
Quarterly data, we broke down the information by quarter, and then the coloring on the graphs that are in the report appear differently too. We had a range of 229 reports in 2010, 592 reports in 2007. The median is 356 incidents, and the mean is 363 incidents per quarter. Each quarter, the information on critical incident reports entered by providers is identified in a chart similar to this. This, I understand, is likely very difficult to read, but this is sent each quarter to all provider organizations that lead CIR person and also to executive directors, and it has information on each of the different provider agencies, total number of people served, the incident count, incident per 100 participants, and then it breaks it down by each of the different categories, A&E, suspected, victim of altercation, alleged perpetrator, etc. And it's actually, there's 2 pages that go along with it. And we look at this information because as a division we look at quarterly if there are trends, increases, and we do that based on sample size, but if there's increases in one incident count to the next each quarter, that would trigger some additional evaluation. This is a piece on the critical incident reporting. So typically, most CIRs will be reported by community support providers, as participants are spending, the vast majority of their time in supports or in CSP settings. And it has been established with the case management change that the entity where the incident took place is who should be reporting the incident. So most of the time, it is the CSP reporting the incident. Some examples, a hospitalization occurs after a choking incident at the group home. CSP reports that highly restrictive technique used at a day setting, but it's not in the person's plan, also reportable by the CSP. Victim of theft, when a person's vehicle is stolen from an unsupervised apartment setting and reported to the CSP. CSP reports. Then a communicable disease reported to the CSP when a participant returns home from a parental visit. It's also CSP reportable. When any provider receives a new report of A&E from a participant guardian, other reporter reports to the division, and mandatory reporting takes place. If a case manager is aware of an allegation previously reported to a CSP, it is not necessary to make the report, and I have a little flow chart that walks through that a little bit, such as if an internal coordinator is now notifying a case manager of an allegation that a participant brought forward, and they say that the mandatory reporting has taken place. And it's also not the case manager's role to ensure that the CSP has made the mandatory report or contact the division. They certainly can ask, and they should be informed if that took place. But we, as the division, assess that information and ensure that those actions take place during monthly representative random samples for SMART, and then during our overall CIR reviews. The A&E reports received by the division, CSP, or case manager related to an allegation needs to be reported to that provider. So some examples is if the division receives a report by our future online form that we don't yet have regarding financial exploitation, or a case manager is notified about neglect occurring at a group home, the CSP needs to be made aware, or if the CSP is made aware of an abuse allegation towards a case manager, that case management organization needs to be made aware. Next, you'll find that flow chart, and we walked through that a bit during our recent case management training here, and it's been edited a little bit since then, but here's your informed entity. So any type of provider, case manager, provider, division, CSP, they are the ones being informed of the situation, whether it is a participant reporting, it's observed, whichever way, and then that informed entity needs to make sure to do their mandatory reporting and also to complete the CIR. Let's say the informed entity is a case management organization being made aware of some alleged exploitation at CSP. they also need to inform the provider of where the allegation occurred. That provider needs to investigate. Note that the informed entity, if it's a case management organization, is not going to be doing an investigation for a CST, and then the appropriate follow-up is shared with the informed, and then they would also complete the CIR. As a requirement with the investigations, the findings need to be shared with the participant and guardian per administrative rule. Preventative measures need to be put into place by a team, and then case management, they need to document and quarterly monitoring the information on the A&E report. Question or anything? Okay. Are there any questions? Of course, use that chat box to document questions, or if there are any questions that you think of after the session, feel free to email us those. I will just jump to the next slide, which has my contact information there and website here.
If there's anybody who did not receive the PowerPoint, I've gotten a couple messages that due to the size of the PowerPoint, it may not have all loaded. So we'll also get a PDF file available of the PowerPoint and send it to you in that version as well.
And then, of course, it'll be launched on the web page. And with the change in the web page, there's a bit of a delay in updated information and access to certain pages, but hopefully, I think that's being resolved piece by piece here. So hopefully that'll be up there soon, along with this recording. And, you know, I might even do a nice clean version of the recording, kind of work through it a little bit more, so the recording will be more succinct without so many interruptions and such. So I might just do that. But any questions, please let us know. And then thank you, Leah, for your help today with walking through the SERP information.
You're welcome.
And if anyone has questions for Leah or anyone else at SERP, you can let us know as well, and we can funnel those to them. And thank you to VOA for being on the line here for information on the pilot that you participated in, and of course everyone for attending and bearing with us through our technical woes today, and hooray, it's Friday at 4:39. We'll wait on the line for a couple minutes if there are questions, but otherwise I think the presentation is completed. Yep, have a great weekend.